Hello, Supun.
Hello, Dr. Inoshi.
Can I start?
Yes.
Yeah, thank you. Good afternoon. So our topic today, right? එහෙනවා නේද? මම video එක off කරන්නම් එහෙනම්.
Okay, Dr. Inoshi.
Right. I have off my video because my connection is very bad. I'm sorry about it. So my topic is management of arthritis, and talking about any particular aspects which are useful for you about in managing patients. I would like you to use the chat if you have any questions as we go on, and I will try to address them during the course of the lecture. So, I am talking about spondyloarthritis, gout, and osteoarthritis. If anybody can't hear me, please send me a message, okay? So, these are the learning outcomes that the pharmacology department would like me to address. So, I will tackle them in a slightly different way so that it will be easy for you to understand. Sasanka, can you hear me now? Can you hear me now?
Dr. Inoshi?
Can you hear me now?
Yes, Dr. Inoshi. I'm Supun here.
Okay. Oh, hello. Mine is not that great either. So let me know if it starts working, okay? So I'll be talking about the principles of management of arthritis. Now, how is that? Is that better? So there are 4 components that I would like to tackle. And if there is any patient with arthritis, we have to first assess how bad the disease is. For example, if you have a patient with blood sugar problems, you have to assess how good the fasting blood sugar is, how good their postprandial blood sugars are, how good their HbA, how the disease is at that point. Arthritis and in other types of arthritis, there are different ways to assess disease activity, and I will tackle it as we go on. Then, like in diabetes, we had to treat the acute attacks. So we glycemic episodes or the hyperglycemic emergencies. Important for you to also prevent recurrent episodes of hyperglycemia. So if a patient is having poor, then we know that the blood sugar medicine was a poor blood sugar control during the next 3 months, then we have to check that. Okay. Then also, so be depending on how the blood sugar control is, and in most conditions like in diabetes or in arthritis, there is a multidisciplinary approach, right? So because of all these things, right, we need to focus on at least treat a patient. So in arthritis, there are periods where the disease is very active. So this can happen in osteoarthritis and in any type of arthritis that I am going to talk about. So side is not important, the plaque. Then we also need to prevent recurrent attacks. If you treat recurrent attacks and you prevent them from happening and they become less and less and less, then you get what is called a remission. No inflammation, and the aim of treatment is to reduce duration of time without flare-ups or increases in disease activity, and so that the patient goes into something called a remission. In diabetes, you can treat the blood sugar targets, but in rheumatoid arthritis, in any kind of arthritis, we need to identify what the target is. We have to assess it every few months, and if we reach the target, we continue, right? If we don't treat it, if the target is reached, you can continue. But if the target is not reached, you have to modify treatment. In rheumatology, and just like in all of rheumatology, including rheumatoid arthritis, the management is multidisciplinary. So if you write an answer and if you are managing a patient, remember, you need occupational therapy input, you need vocational rehabilitation, you need physical therapy, you need psychological support, you need the assistance of the orthopedic people, you might need a social worker to give them money and help them work, and you also need rheumatology services. In other countries, there is a nurse who links the rheumatology services with the GP practice, and the GP manages the patient in primary care. So this is kind of like the model that we have to manage these patients. If there are any questions, please ask. Any questions? So let's focus on the management of rheumatoid arthritis. So this is a brand new guideline. It's so new that it doesn't even have a number yet. It's actually just accepted for printing. So it's brand new. And you know, rheumatoid arthritis is a disabling, damaging disease condition. You have early arthritis, intermediate arthritis, and late stage arthritis. Early arthritis is when the arthritis is less than 6 weeks old. Established arthritis is when the arthritis has been long-standing and patients usually fulfill what the kind of disease criteria we used when we were medical students. So I was a medical student 25 years back. So that's how old those established arthritis criteria are. Actually, it's older than me as well. Any question? Has anyone seen, has anyone been, is anyone familiar with arthritis criteria, diagnostic classification criteria for rheumatoid arthritis? Anyone? Has anyone been, is anyone familiar with the arthritis classification criteria for rheumatoid arthritis? Can someone type in something? Okay, you all know the ACR criteria. Which one? Isuri, the 1987 one or the newer one? I don't mind you talking as well if you like, or you can chat. Okay, not sure, that's fine. Okay, I'll go through them. So I think we've done the early rheumatoid arthritis criteria in your musculoskeletal module, and it deals with a cutoff of less than 6 weeks, more than 6 weeks, and there is joint pain and tenderness. So those are the ACR EULA criteria, and they were in the early 2000s and later on with revisions. But I think in your textbooks, you will mainly see diagnostic classification criteria for established arthritis. So this is the kind of patient. Can you see my slide? Right. So an older woman with long-standing arthritis who has not really taken treatment, and she has lots of deformities and rheumatoid nodules. So she has what is called established arthritis. And is this the kind of criteria that you all are familiar with, or the earlier ACR EULA criteria? Which one? I have not read your text. Yeah, the EULA one. Yeah, so the EULA one is very different because it doesn't have this kind of thing. It does not have X-ray changes in it, doesn't talk about nodules, and it counts joints rather than using 3 or more. So it is better for people to use this to the EULA criteria, which are in the 2010, 2012, 2015, those kind of period is better because it picks up early arthritis. So identifying early arthritis is very important. And you know that people who have long-standing high disease activity, people who have very swollen joints, people who have erosions, people who have tried many disease modifying drugs, people who have very high rheumatoid factor or anti-CCP antibody titers, they do very poorly with treatment. So you need to identify this aspect also. So when it comes to rheumatoid arthritis, because we don't have one test to diagnose it, to assess how bad it is, there are multiple disease activity assessment criteria. So you don't need to know how to do these individually, but you can read up maybe one of these criteria that suits you, and you can use it. There is a difficult calculation for DAS28, but I do it on an app, and most people do it on a computer. So it's quite easy. It takes me less than a minute to do the DAS28, right? Some people use this SDI, right? Which is also very useful to use in clinical practice. And if you don't have a ESR or a C-reactive protein, as is common in our setting, you can use the CDI, okay? So you don't need to know individual details. If you can note one, and if you can just name the others, that would be more than enough. You're not expected to know the details. You just need to know rheumatoid arthritis has disease activity scores. So the importance of treating early and the importance of having the disease activity criteria is because there is a period of reversible early autoimmune phenomena, right? Okay, so during that time, we can potentially treat the patient and achieve what we call a remission. But if you achieve this end of the spectrum, right, if you go into progressive disease, it is very, very difficult for people to treat. Do you remember the small group discussions that you had in pharmacology? Anyone? Did they talk about a window of opportunity to treat rheumatoid arthritis? What did they say? Can someone speak up and tell? I'm getting a little tired of listening to my own voice. Anyone is fine. I think they spoke about the window of opportunity. They frequently ask about it as well in your questions. Anyone can tell me any one thing about this window of opportunity? I've already explained, yeah? Yeah, so as was told, yes, there is an early treatment window, and the earlier treatment window is better. And yes, our aim is to treat within the first 6 weeks. Though the 6 weeks cutoff is there, I'm telling with clinical practice in developing countries, we generally wait till the 6 weeks is just over to start treatment, because sometimes we might have viral infections which might mimic arthritis, hepatitis B, hepatitis C, a retroviral infection, all of which can mimic rheumatoid arthritis. So we tend to wait at least 6 weeks and then to treat. Okay. In other countries where we can do the whole panel of virology before, we can treat them early. But the window of opportunity is to treat the condition as soon as possible within that reversible autoimmune period before the autoimmune cascade gets fully established. So there are many treatment options for patients with rheumatoid arthritis. What kind of treatment options have you all met? Maybe 2 or 3 people can type in. What have you all seen being used in the wards when you went for your medicine appointments, when you went for your rheumatology appointments? Yeah, tell me, Vihanga, what kind of DMARS? Just mention one name. Tell me what kind of drugs these patients got. So most got methotrexate. What did they get for pain? Pain? They got non-steroidal anti-inflammatory drugs. Any others for pain? Paracetamol? Any other things? Okay, one other drug which is very useful in short-term flare-ups is steroids. Yes, very good. Yes, short courses of steroids, intramuscular or oral, are very useful to control the flare-ups of rheumatoid arthritis. And there is actually research to show that if you use short-term steroids, that your chances of remission are much higher. I put this up to show you how things went with rheumatoid arthritis. This is kind of the milestones in rheumatoid arthritis. So in 1900s, that is way before any of our parents were born or grandparents were born also, I think they usually gave aspirin. That was only an inflammatory drug. Then they started giving steroids. And you can see that methotrexate was a gold standard for well over, my gosh, 1975. So that is at least 40 odd years, right? And then we saw that people were dying and that there was a lot of radiographic changes. And then in the year 2000, and this is just a little before your ACR-EULA criteria, biologic DMARS came to play. What are the things that people are worried about with taking disease-modifying drugs? My patients are terrified. What kind of questions have patients asked you about disease-modifying drugs? Anyone? You all can ask the question audio. That would be nice as well. Or you can type it. Anyone? What kind of questions do patients ask about methotrexate? Yeah, what side effects? Yeah, they're very worried about alopecia. They are worried about kidney disease. They are very worried about hair loss. And they will always ask you how long they have to take. Yes. Ulcers where? Tummy? Mouth? Oral ulcers. Yeah, okay. So they are worried about mouth ulcers, really? Patients don't usually ask about mouth ulcers so much, but people who have been on methotrexate do ask about mouth ulcers. But most patients, before they start, they ask about kidney failure, because people are conditioned to thinking that all the drugs given for arthritis cause kidney failure. They are worried about hair loss. And another thing that they ask, frequently people ask, it's a cancer drug. Can I get cancer? I don't know what the logic is, but they keep on asking that question. So anyway, so just to tell you, I think pharmacology has told you all this again before as well. Whoops. So there are synthetic disease modifying drugs and there are biologic disease modifying drugs. We have conventional disease modifying drugs, that is methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. And we have targeted synthetic disease modifying drugs. Has anyone seen these drugs which I have put under targeted synthetic disease modifying drugs? Anyone? They just became licensed in Sri Lanka, so I don't think you would have seen it in clinical practice. Someone has talked about teratogenicity. I will address that as well. So then, of course, there are the biological disease-modifying drugs, original disease-modifying drugs, and what are called biosimilars. Original disease-modifying drugs. So biologicals, the development of biologics is different to the development of chemical drugs, right? So there is a particular biological pathway because these molecules are biological molecules. So that particular biological pathway of synthesis gets a patent, and the company who developed the original drug owns the patent. So you can buy Mabthera, which is rituximab, for about more than 2.5 lakhs. This is before the dollar went up. So, but there is a biosimilar, which is a similar molecule, not identical. It is not like a generic and a brand. It's very different. But they are similar, not identical. So those kind of drugs can be maybe 15-20,000. So there's a big difference in price. So this is a very important structure for you to remember. I don't expect you to remember the details, but I would like you to remember the structure, that there are disease modifying drugs which are synthetic and biological, and the synthetic disease modifying drugs are conventional disease modifying drugs, and the targeted disease modifying drugs. All these kinibs are what call Janus kinase inhibitors. I suppose I should type that to everybody. You must have met these drugs in your oncology appointments, maybe, right? So these baricitinib, tofacitinib, those are targeted molecules. Then you get biological disease modifying drugs, the original one and the similar one. Okay, so that is enough for your biological knowledge, really. But we need to know how to do this. So this is exactly what I talked about. You have a disease, you assess the activity, you assess it every 1 to 3 months till they get remission. And if they are in sustained remission, everybody is happy. If they are not, and they continue to have disease activity, you need to figure out what to do. These are the synthetic disease modifying drugs you all must have seen. Anyone in this list which you all have not seen in clinical practice? Anyone? Any drug which you have not seen? Hydroxychloroquine, everybody has seen? Yeah? Much talked about. Leflunomide, methotrexate, sulfasalazine. Yes, okay. Methotrexate was supposed to have been higher up and top of the list. I don't know what has happened to this particular slide. So hydroxychloroquine, everybody wants it. Trump wants it. Sajid wants it, right? But I think it is best reserved for the rheumatological indications as we currently know it, rather than for COVID. The mechanism of action of hydroxychloroquine is not very well understood. It basically stabilizes the lysosome. It also modulates the T cell actions, right? There are lots of problems with many disease modifying drugs, but hydroxychloroquine seems to be generally safer. Some people have a bit of nausea, vomiting. A lot of people are worried about macular damage, and macular damage tends to be happening when you use the drug long term. right? And are there any questions that people want to ask about this? Any questions? A lot of my girls won't use hydroxychloroquine because it causes skin pigmentation and they become like a slate gray color and they don't like to take it. Are there any questions you want to ask about hydroxychloroquine before I move to the next slide? You can ask it via audio rather than chat if you like. Nirasha, I can't hear you. Nirasha? Any questions you want to ask or shall I move on? Please ask. It's very nice if you can ask. This artificial sort of lecture giving is not my style. I would like to see your faces, but it's not possible with this current internet connection. Anyone wants to tell me? Or you can type it in the chat. Any questions you want to ask about hydroxychloroquine? Okay. I'll move on to the next one. Methotrexate, people know. It's the most useful disease modifying drug. Okay, can HCQ be given alone? Let's go back to HCQ. Yes, it can, but in real seropositive rheumatoid arthritis, HCQ may not work as well in the long term. You might have to add on methotrexate. Personally, I prefer to give methotrexate. Hydroxychloroquine is an adjunct or an additive treatment, but there are some patients who have rheumatoid factor negative, who are anti-CCP negative, who barely fulfill features of rheumatoid arthritis, and they want to have a child. Those people can be given hydroxychloroquine. Did I answer your question, Duvindu? Yeah, it can. So it depends. Mild RA is a question of how. So Vihanga's question is hydroxychloroquine given for mild RA? So in general, if rheumatoid arthritis inflammation is minimal and there are no poor prognostic signs, like they don't have huge joint swelling, they don't have anti-CCP antibody positivity, if they don't have rheumatoid factor positivity, if there are no erosions, and you can monitor this patient with regularly, you can try hydroxychloroquine. But if it's full-blown rheumatoid arthritis, the answer is no. Whether it's mild or not, if the anti-CCP antibodies and rheumatoid factor are very strongly positive, you need to give methotrexate. Is that okay, Vihanga? Okay, let's go to methotrexate. Anyone wants to clarify? Yeah, okay, fine. So methotrexate is given once a week as 15 to 20 milligrams, and it is generally quite a safe drug. We have taken it since in Sri Lanka since the 1980s, and the patients are very scared because they think it's a cancer drug. So I don't know what the logic is, but still they are very reluctant to take it. They are worried about teratogenicity, but in reality the teratogenic effects are minimal, and all our patients who are on methotrexate are told to be on a family planning method, right? You need to counsel people about using alcohol. You need to assess their liver function and full blood count before starting the drug, right? Because very rarely, right, I'm talking about 1 in 40% of white people might have liver function abnormalities, maybe about so various percentages of people can have uh, liver function, full blood count abnormalities. So you need to monitor a baseline test and then do it as you go on, right? Side effects, yes, include oral mucosal ulcers, liver damage, lung toxicity is very, very rare. Bone marrow suppression is very, very rare. We tend to give folic acid on a different day so that these mouth ulcers and the GI side effects are less. But if you get what we call severe palatal inflammation and mucositis, you have to stop the drug. Okay. The mechanism of action of methotrexate, as we were told when we were medical students, is by affecting the lymphocyte proliferation. But there are many other pathways which inhibit pro-inflammatory action, which we inhibit the inflammatory action. It affects apoptosis, it affects cell multiplication. So the mechanism of action of methotrexate is very it's very complex. Okay, any questions you want to ask about methotrexate? Yes, you all asked about teratogenicity. So methotrexate has to be stopped 3 months before conceiving a child. I advise male patients and female patients also, right? People tend to only advise the women. I also tend to get them to write and sign that I have advised them on the side effects of methotrexate. Okay? Any questions about methotrexate? If there are any questions, just type it into the chat. Any others about methotrexate? If there are, please type in. Okay. So sulfasalazine, nobody really knows how sulfasalazine works. It has an anti-inflammatory activity, and that is because of one component of its molecule. It's a yellow square color tablet. We give it twice a day. You can have blood count abnormalities and you can have liver function abnormalities. Okay, so there's a question about hydroxychloroquine and methotrexate. Very rarely do patients refuse hydroxychloroquine first because of skin pigmentation. I think the treatment of choice is methotrexate, and methotrexate has higher efficacy. Hydroxychloroquine is treatment of choice in lupus, which I am not talking about today, but methotrexate is the treatment option. You cannot compare the efficacy of methotrexate with the efficacy of hydroxychloroquine in rheumatoid arthritis. Methotrexate is much, much more effective than hydroxychloroquine. But when you add the two, the effect is exponentially effective. Okay, I hope, Chandu, that I have identified that. I have answered that question.
Yes,
okay. Yeah, so about skin pigmentation, most patients don't, though you talk to them when you give it, nobody really refuses the drug. This is in my 20 years. Nobody really refuses the drug. They have to keep on taking it at least for about 6 to 8 weeks for them to get pigmented. I've had very few patients discontinuing the drug after telling me, but I think it's a significant problem in our South Asian cultures where people want to look fair. In Western cultures where people want to look tanned, they voluntarily request hydroxychloroquine. Okay, so different people, different things. Okay, I hope that was clear. So then there is another drug called leflunomide. Leflunomide is as good as methotrexate efficacy-wise. You give 10 to 20 milligrams per day. Again, it interferes with lymphocyte multiplication. The side effects are very much similar to methotrexate, and the profile is similar, but the chances of you getting side effects to leflunomide are much lower than in methotrexate, if that is clear. Is that clear? So they are similar drugs, similar side effects, but the incidence of side effects is higher in methotrexate than in leflunomide. It's a very useful drug. It is more expensive than methotrexate, but patients tolerate it quite well. In our country, we do see blood pressure changes. So I tend to measure the blood pressure as well, because in Asians, there are blood pressure fluctuations. Okay. I need to put it up on the slide. It's not there. Please write it down. So the mechanism of action, as I said, is due to the multiplication of affecting the multiplication of immune cells. So this is what I wanted to tell you. So most of these drugs, which are conventional disease modifying drugs, act on T and B cell proliferation, right? And they also, but the biologics, they actually target particular things. Now nobody really knows exactly how the glucocorticoids and non-steroidals suppress inflammation in rheumatoid arthritis, but they basically are believed to act via the innate immune system and not via the adaptive immune system action. So they they block the innate immune system response to inflammation and not the adaptive immune system, which is why the glucocorticoids and the non-steroidals work very, very quickly. So these are the biological disease modifying drugs. If you can type this and mention infliximab and adalimumab as anti-TNF therapy, I am more than happy. We have rituximab, which is a B-cell agent, and we have interleukin-6 blockers, and we have interleukin-17 blockers. Okay, there's a very nice question which has been asked by Duvindu. If both are similar and there is less chance of side effects, why is leflunomide not the drug of choice compared to methotrexate? Methotrexate has two big advantages, right? The side effects of methotrexate are rare. The side effects of leflunomide are rarer still. But methotrexate is so much cheaper, and it has, as I said, 40 years of experience backing it. So I think methotrexate is a better drug of choice than leflunomide for those reasons. The side effects of methotrexate are very, very rare. I put them up because as doctors you need to be informed, but they are very rare. Okay, I hope I answered your question. So what drugs are preferred during pregnancy? Very good question. I'm not sure what your real name is. You're a 3-letter person on my phone. But yes, hydroxychloroquine is safe during pregnancy, and we now know that sulfasalazine is safe. I have trouble convincing the obstetricians, but their evidence is very clear. Methotrexate and leflunomide are contraindicated, and so are the biologicals. Okay? I hope we clarified that. So, as we go on, any more questions? Happy to answer. So I just put this picture up for your interest, just to show that we have antibodies which are stuck to something called a fusion protein and another antibody. So these molecules are very complex, but those molecules which have Z-MAB in it have a mouse component, and they are much more allergic. People are much more allergic. I hope you can see that the infliximab has a mouse component, so the patients tend to get more allergic. Rituximab has a mouse component, again patient tends to be more allergic, right? And they have a very targeted action, so they are essentially quite safe, but we don't have the experience to back it, so which is why we are scared. And I think since I last did the lecture, we have got a Th17 blocker in Sri Lanka. So that blocks the Th17 cell. So we were blocking small molecules. And then we are blocking the Th17 interleukin 17 molecule. Okay. So we basically target a molecule which is active during rheumatoid arthritis and block it. And these are again to show you that most are injections, and there are few infusions. In other countries, we prefer injections over infusions because the patients can take it at home. our patients need to come in because we have still not figured out a good primary care system to deliver these drugs. And each drug vial costs about 1,50,000, 200,000. So we have a problem of accounting for the drug loss. So that's why patients come in and take the drugs. I just wanted to tell you there is this organic small molecule which we can block. It is again targeted, but it is a drug. It is not a biological molecule. It is not a protein. Okay. So because of that, these Janus kinase drugs have a very good efficacy, but they are tablets. So patients prefer it, but they are very expensive. So they just came into the market at around the time COVID came. So we've still not used it a lot in Sri Lanka. There are only a few. So the main thing that you need to remember is start with disease modifying drugs early. Start methotrexate if there is no contraindication. You want to achieve low disease activity, monitor the patient every 3 months, and modify treatment if the disease remission is not achieved. Sorry for pausing. I was trying to read a really good question here. So somebody again, a 3-letter person. Who's ENV? Can you type in who you are so that I can address you if you don't mind? So are biologics superior to synthetic disease modifying drugs? Yes, they are superior to the conventional synthetic disease modifying drugs. They are equal to what I call the Janus kinase inhibitors. I hope I answered your question. Please chat and tell me if you did, if I answered your question. Right. So the main thing, start methotrexate with steroids, and if that is not working, add on leflunomide and sulfasalazine. Monitor the patients 1 to 3 monthly, continue it. And if the patient is in sustained remission for at least a couple of years, you can decide on tailing off the drug. Okay, so this bit is just for you to know. You will get this handout with you. It's just to tell you that if the conventional disease modifying drugs don't work, we have different other molecules we can change to. Nothing compensates for a multidisciplinary team, right? So psychosocial interventions, rehabilitation interventions, crutches, walking sticks are very, very useful. Complementary and alternative medicine, I tell patients use if it is not harmful. Some people are taking turmeric, others are taking garlic, others are taking bees honey, but there is nothing to show that it works. Fish oil, again, nothing really hard and fast for rheumatoid arthritis. So monitoring of rheumatoid arthritis can be quite expensive. Blood tests, if the patient is paying for or the government is paying for, cost about 3,000 rupees. And if you have to monitor them regularly, that is a problem. Hydroxychloroquine doesn't need blood monitoring, but methotrexate and leflunomide and sulfasalazine need every 2 weeks blood monitoring, and then once they are stable, every 3 months, right? So I just wanted to tell 2 slides about psoriatic arthritis. Similar kind of process of management. I won't discuss it in detail, but there the disease activity of the arthritis and the skin are assessed by 2 categories of scores, and the similar synthetic disease modifying drugs are used, but we have different, these are the psoriatic disease activity indices. No need to remember that. This is just for you to know. You have to assess disease activity, and there are slightly different drugs in terms of biologics. One is this interleukin 23 molecule blocker. Y'all, ladies and gentlemen, you're not expected to know in detail what molecules are there, but if you know what the molecular target is, TNF alpha, interleukin, that is enough. If you can name a few agents, that is exceptional. Okay, so are there any questions you want to ask me as we go on to the next section? So if you can see, all these guidelines are brand new. Now, this doesn't have a number either, right? Okay. So spondyloarthritis is a multiple spectrum disease. You get ankylosing spondylitis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease, uh, and uveitis. So it's a complex group of conditions. I'm waiting for chats to come about the rheumatoid arthritis management. Is there anything you want to ask? Okay, I'll move on with spondyloarthritis. So there is axial spondyloarthritis, which affects the cervical, dorsal, lumbar, and sacroiliac joints, and also the peripheral arthritis, which affects the knees, the ankles, the hips, the wrists, and so on, right? So this, you have the different types of arthritis, and you have the different patterns of spondyloarthritis, joint affection, and which is what I have put here in box 1. So you know that you start off with inflammatory back pain, which generally first shows up only on MRI. As time goes on, you see small X-ray changes, and in time, the whole spine gets fused. So we know that there are multiple molecules which are involved in the pathogenesis of ankylosing spondylitis. I will not go through with it too much because we have discussed it in a lecture. Again, you need to assess disease activity, and you can download the app from the Google Play Store or the App Store, or you can get a web link. You classify patients into low disease activity, high disease activity, and very high disease activity. And you also, then depending on how that is, you classify the patients and treat them. Are there any questions about ankylosing spondylitis that you would like me to address before I move on to management? Please type in. Oh, okay. There's a cool question. Where is that? Sorry. Okay, so the disease activity criteria, the DAS28 criteria, those are the ones which we use to show whether the patient is in remission or not. So we can talk of a DAS28 less than 2.1, and then we don't stop the drug, we taper off the drug. We are talking about rheumatoid arthritis, that's Kavi and me. So we are talking about rheumatoid arthritis. In rheumatoid arthritis, when the patient is in sustained remission for a couple of months and most often a year and a half, we gradually taper the drugs. We don't stop. If you stop, you get a flare. We gradually reduce and see how the patient behaves. Okay? It's like a lockdown. You slightly release it. Did I answer your question, Kavi? Okay, fine. So any questions about ankylosing spondylitis? I'm happy to address any questions as we go on. Okay, so in ankylosing spondylitis, drug treatment is adjunct. It is an additional component. You can use non-steroidal anti-inflammatory drugs, physical therapy, but we generally don't use systemic corticosteroids. Very rarely we use systemic corticosteroids, but as a medical student, remember non-steroidal anti-inflammatory drugs and physical therapy. As a rheumatologist, yes, occasionally we use systemic glucocorticoids depending on a particular patient's disease pattern. You need to, so you diagnose active ankylosing spondylitis. You diagnose the disease as ankylosing spondylitis. You use the ASDA score to assess the disease activity. Then you identify whether there are additional arthritis problems, right? For those, you can inject the drugs or give conventional disease-modifying drugs. Sulfasalazine seems to be better than methotrexate for these conditions, right? And if you have, only enthesitis. I have a question from Sharka, but I will answer that. Give me a moment. So in isolated sacroiliitis or enthesitis, you can use only non-steroidal anti-inflammatory drugs. You can use local steroids. So the very important question that has been asked from me is, trying to look below the chat here, right? Why do you not inject glucocorticoids to the peripheral entheses, right? You don't inject glucocorticoids to weight-bearing peripheral entheses of the Achilles tendon. You can inject the entheses in the elbow, you can inject the entheses in the heel. You can't inject the Achilles tendon because it is very fragile, it is weight bearing, and it is a strand of muscle which carries the weight of the body. Okay, and if you are going, when you're walking, one Achilles tendon carries the weight of the body, so you can't really offload that ankle after steroid injection, and you have a greater tendency of tearing because of the structure of the Achilles tendon. Okay, so I hope I answered your question. Quadriceps entheses, same problem. Patella entheses also same problem, right? I hope so. Only for the peripheral weight-bearing entheses, which are mainly muscle and which are not, mainly entheses which are not backed by other entheses or muscles surrounding. I hope I answered your question, Sharka. Right. Physical therapy is very important. I have many patients who are managed, who are young, who do exercises regularly, who have managed to control their drug with anti-inflammatory drugs, swimming, and physical exercises. This bit is very, very important. So, non-steroidal anti-inflammatory drugs are preferred as starting, but if patients have very high disease activity, we use the SDAS now, not so much the BESDI. We can treat patients with biologics firsthand, but we tend to go with this older model because biologics are very expensive and difficult to fund. We try non-steroidal anti-inflammatory drugs, we try local injections, we try a trial of sulfasalazine. If it continues to be uncontrolled, we then go for biologic. Sharka, did I answer your question?
Yes, ma'am.
Okay, sorry. It's Sharaka, right? Sorry about that. Okay. My bandwidth does not permit me to see your faces. Sorry about that. Okay, so which drug to get? Naproxen and celecoxib have been tried, and depending on the GI risk, we tend to give patients whichever drug which is available. Coxibs are less GI toxic, so we give the GI. So for people who have risk of GI ulcers, we tend to give the coxibs. The others we can give naproxen. Naproxen is supposed to be safer in cardiovascular disease, but now we know that coxibs may not be that bad, but still generally we give naproxen for low GI risk, and celecoxib and coxibs for the high GI risk. So this is how the anti-inflammatories act. You don't need to really I don't need to go through this because pharmacology, I went through their small group discussions, they discuss it very well. And you can use anti-TNF therapy, and this is the slide which last year's people got. And this is the slide you're getting because that's a newer molecule which has been approved for ankylosing spondylitis. So these Th17 cells which secrete interleukin 17A are very, very critical in spondyloarthritis, right? So second line therapy, as I said, is given to you just so that you know some things can be done. In stable ankylosing spondylitis, we can manage with non-steroidal anti-inflammatory drugs on demand. if patients have severe spinal deformities, even I think we don't like to do so many surgeries in these patients, right? So I went through all this, so we don't need to talk about it. Any other questions about spondyloarthritis? Any questions? Please ask. See, I can't see your faces. I have no clue who you are. I don't know if you're a boy or a girl. So please ask. At least I've got questions this time. So please ask any questions about spondyloarthritis. Have you seen patients? No questions on spondyloarthritis? Ask one before I move to the next one. Anyone? About drug treatment? Maybe you know someone who has spondyloarthritis. You can ask a question on their behalf. Feel free. Is there anything you want me to explain more in that section? You're sure? Can we ask the representatives? Oh, yeah. Okay, here we are. Nice questions coming up. I do like to get questions, and I'm now trying to navigate my, oops, right, okay. Okay, some nice questions. Is there a complete cure of any of the spondyloarthritis? Yes, there is a percentage of remission in spondyloarthritis. Do all spondyloarthritis patients absolutely not. Not everybody requires joint replacements. I have patients who are doing very well on drugs. People who have been treated early with good physical therapy and good attention and follow-up are very good. Some people have horrible disease. Those people, when treated with biologics, do very, very well, right? People who were unable to get out of bed and walk, like 20-year-olds like you, they suddenly can do ballroom dancing, anything. They can do anything, right? There are people who are professional athletes who are having biologics and who have spondyloarthritis. There are some athletes who are managing only on conventional drugs and non-steroidals, right? Bamboo spines, no fascial or fascial, they are not reversible. They are irreversible. But some of the flexibility may be got by the biologic agents because, oh, there's a really nice question. I'm Dilanka, are you a female or a male? Or Dilanka? Anyway, HLA-B27 positivity is used in white people to classify patients and to choose patients as disease. In our Sri Lankan cohort, HLA-B27 positivity is not very common. It's not really a prognostic factor. It is a better diagnostic factor. If it makes sense, it's better for diagnosis than for prognostication. There are other genes which are more useful for prognostication than the HLA-B27. It's a very good question. Any more? Okay, another nice question. If a patient presents with spinal involvement of rheumatoid arthritis, how to differentiate it from ankylosing spondylitis? Okay, the spinal involvement in ankylosing spondylitis is very different from rheumatoid arthritis. In rheumatoid arthritis, spinal involvement occurs mainly in the cervical spine, in the atlantoaxial joint, whereas in ankylosing spondylitis, it is mainly a disease of the enthesis rather than of the joint. So there are a lot of the radiological findings will be able to differentiate the two. That's the first thing. Clinically, the pattern of involvement is cervical in rheumatoid arthritis. In ankylosing spondylitis, it is usually lumbar sacral and then cervical rather than cervical first. People with rheumatoid arthritis can have degenerative changes and they don't have inflammatory features of ankylosing spondylitis. I hope I answered the question, Kavi. Okay? Can I move on? Okay, right. So let's move on to the management of gout. Gout is not rare now. It's actually much commoner than when I was a medical student many decades ago. So this is a 70-year-old man with a painful big jaw who has micro and macrovascular complications, very heavy alcohol use, takes a diet rich in meat and seafood, right? So because of all those reasons, he has a history of, he has features of acute gout. So gout can be acute. I hope you can see my cursor. There is a swelling of the big toe that is in gout. This is chronic tophaceous gout. And you can see that there is like whitey material coming out of these joints. That is a very deforming type of an arthritis. So gout is an inflammatory arthritis caused by accumulation of excess crystals, and these crystals of monosodium urate can be deposited in the joints, tendons, bursae, and any other site. And when these crystals are very inflammatory, they cause the neutrophils to, they attract the neutrophils and they are phagocytosed by the neutrophils, and there is release of those lysosomal enzymes I talked about, and there is a very profound inflammation which happens. So gout is a chronic disease, and as I told, and it has 4 stages. Asymptomatic, patient is fine, no problem, only the uric acid is elevated. Then you have patients who have acute episodes of joint swelling with in between periods without anything. And then when you have advanced gout, the patient has constant pain, constant joint swelling and inflammation, and the hyperuricemia gets worse and worse and worse. So this is what I wanted to tell you. And in the acute intermittent arthritis, in the initial phases, they are very short episodes. And as they go on and on, it becomes worse and worse. And then at a particular time, you just get constant pain with episodes where that pain is very much worse. Okay, just look at this slide for a few minutes. Are there any questions? Okay, so I like to think of the management of gout as like I told you, like rheumatoid arthritis and diabetes. Gout, we must think of like it has a lot of flares on a background of a chronic disease. So it is like something like maybe asthma. You get episodes of flare-ups of asthma on a background of chronic disease. So what you do is you need to manage the amount of uric acid you put in. Can anyone mention a good source of uric acid? Please type in or talk. I'm getting very bored with the sound of my voice. What meat? Red meat, okay. Our people don't take a lot of red meat. Yes, beer, national drink of Sri Lanka. Yes, seafood. Yeah, a lot of seafood, beer, and alcohol is very common in Sri Lanka. So that is very common, very one of the main triggers. Seafood, yes, and certain types of beans can also cause gout flares. So you need to limit the amount of uric acid you put in, because we don't have a facility in our human body to break down the uric acid. Okay, so this is to recap what we told you about gout, that the diet gives you purines, and these purines come into the body. They are excreted by the kidney, right? And if there is reduced uric acid elimination, or you pump in too much uric acid, you can get gout. In reality, you have to have a tendency in your body to reduce which reduces uric acid elimination. So when you have that tendency, either genetic or due to renal impairment, you pump in uric purines from food, then there can be issues. So these are the foods that you should be able to avoid, right? That my patients are asked to avoid, right? And then they ask me, what can I eat? You're telling me not to limit the seafood, don't take red meat, reduced purified products, stop alcohol, what can I eat? So in actually it is a pyramid, right? You can take lot of vegetables essentially, and you must moderately take the others, right? But some patients say, every time I eat prawns, I get gout, in which case those prawns have to be stopped. Okay, so this pyramid is there in terms of the dietary intake. It's all about a dietary balance. So how do you treat the patient with a swollen acute gout, swollen joint due to acute gout? You can use inflammatory drugs. These are very stiff doses of anti-inflammatory drugs. And in our patient, the 70-year-old with renal problems, it's not possible to use them. You can also use colchicine, right? I tend to use lower doses of colchicine, like about 0.6, 0.5 milligrams twice a day, and then to take it gradually build up. But if you have acute gout, you can use it's better to divide up the dose, because patients don't take colchicine very well, tolerate it very well. Steroids work very quickly, and you just need to give it for about 5 days, 1 week, and it settles the attack very well, and the patients tolerate it a bit better than colchicine. This is to show you how allopurinol, the xanthine oxidase inhibitor, works. And if you want to prevent recurrent attacks, so it's like this, like in bronchial asthma, if you want to prevent attacks, you have to take long-term inhaled steroids, you have to take, and you have to modify your risk factors. In gout, you have to take long-term allopurinol if you have meet certain criteria, or febuxostat. Febuxostat is a drug which is better in renal patients, but there is a slight cardiovascular risk. Probenecid is a uricose uric acid. So allopurinol and febuxostat change how we handle uric acid in the body. Probenecid increases the uric acid excretion, right? So if you want to prevent it, you reduce the formation or increase the excretion. But the acute attacks are like, if you have bronchial asthma, you treat them with beta agonists, beta-2 agonists, like that. Here you treat acute attacks with colchicine, steroids, or if the patient's kidney function is okay, with non-steroidal anti-inflammatory drugs. Allopurinol needs to be taken with a lot of hydration, okay? It's very, very important. And there are particular precautions for taking it. See, a lot of glass to be drunk, glasses of water to be drunk. So you need to check the full blood count, the renal and liver function before you do it. Right. Question. Yeah, patient, I will tackle this particular one as we go on when I talk about the principles of management. So give me a moment. So you need to monitor the liver functions and the full blood count. Skin allergies. There is a fatal skin rash which can happen. Okay, and that you have to avoid that, right? So if the patient develops even one skin lesion, they must stop the drug. Febuxostat is generally easier to tolerate, but as I said, after this slide was made, and I have forgotten to change that, there is a black box warning about cardiovascular risk. So you have to be careful in using patients with high cardiovascular risk. Okay, some questions which I will answer. Right. So the dietary recommendations we have gone through. Who do we treat? We treat people who have chronic tophaceous gout. We treat patients who have more than 2 episodes of acute gouty arthritis. We treat patients with anti-gout treatment if they have chronic kidney disease. We treat them if they have previous uric acid urolithasis, right? Okay. So your treatment target is to keep the uric acid less than 6 milligrams, and allopurinol and febuxostat are the first line drugs. And this is the question you're asking. You need to use anti-inflammatory prophylaxis, right? When you start allopurinol, and oral colchicine is the first line to prevent it, and you can use low dose anti-inflammatory drugs. I'll start with Pravini's question. After how long of an acute attack should we start allopurinol? At least 2 weeks after the acute attack settles, you can start allopurinol. Why do you take it under non-steroidal anti-inflammatory cover? It is because the fluctuations of uric acid are the ones which trigger gout. So when you start taking allopurinol, your uric acid, which is 9 milligrams, drops to 6 milligrams, and that fluctuation can trigger an attack of gout. So that is why you have to take allopurinol with prophylaxis. Why is there a preponderance from the grade 2, right? So the uric acid crystals tend to home in on colder points of the body, and your big toe is probably the coldest point, unless you talk about in our country, definitely so. In winter, some people tend to have a preponderance. The coldest point is probably the tip of the nose, but that doesn't have a joint. Okay, so because of that reason, there is a tendency for the gout crystals to come to the big jaw. Are there any questions? Any more questions? I hope I have identified your, answered your questions. Okay, can I move on? If so, gout, you need to know. There's a lot of chronic kidney disease in the country. People are getting fatter and they are drinking more and more. So because of this, gout is now coming to be now not rare. Okay, it's there in a lot of patients, and you need to be able to manage gout. There was a time when we would see one patient for the whole week with gout. Now we see one much more than that. So I'm going to the last section of my lecture. Are there any other questions you want to ask? I think Peshala and Pravini, I answered your questions. Are there any other questions about gout? Okay, I'll move on to osteoarthritis then. So osteoarthritis, as you know, is a musculoskeletal condition which occurs in older people. And it is generally in part degenerative, though there is a very small inflammatory component. Again, new guidelines, 2019 end, actually came again in January this year. So all 3 guidelines are fairly new. So what works in osteoarthritis? Weight loss, exercise, right? Pharmacological treatment does not work very well. So how do you assess osteoarthritis? There is no disease activity score for osteoarthritis yet. There is only functional measures, but we can't use them to guide treatment. You can use them to modify treatment, but they are not, like you can't say my DAS28 is this much, so I must change my DMAT. My SDAS is this much, so I can change my biologic. It's not like that. For osteoarthritis, there is nothing where we can really assess completely an activity score. How much weight loss? At least 5%. Ideally more than 10%. For you young people, losing 10% of your body weight, that is, if you're 65 kilos, to lose 6.5 kilos may not be a problem, but as for older people, it's very difficult. So the paradigm is that osteoarthritis is brought on by mechanical derangements in the majority of people. So if you reduce your weight, the load on your joints is less and your disease becomes better. It's like this vehicle, right? It will not move. It cannot move. It's overloaded, right? So unless you, and it's not a brand new vehicle either. So it's not going to get these so many hundreds, so many 20, 30 people much, right? So it's like that with the osteoarthritis. You get a aging joint, and if you put too many people on it or too much weight on it, it's not going to move. So the more you lose, the better it is, and the better your pain improvement is. So what kind of exercise, people ask? Because older people now, funnily enough, more people are going to the gym, and I do have 70-year-olds and even 80-year-olds who are exercising at the gym. Some of my 20-year-olds don't do it, but the older people do. So there is a question of what kind of exercise you can do. If you're someone who has been exercising all your life, continuing it is not a big problem. But if you're a 70-year-old, it's difficult to start a new exercise. If you're a 60-year-old, it is a bit tough. So what kind of exercise? Tai Chi is supposed to be very good. People don't use Tai Chi very much in Sri Lanka, but I do know there are some patients who go for Tai Chi. It's very good. It improves flexibility. It's about so it's a very good kind of exercise for patients with osteoarthritis. Yoga, yes, I can't do that posture. So I don't know how many of you can do it, but clearly most of my 70-year-olds cannot do this. So they have developed chair yoga for those patients. Again, this to improve the flexibility and strength, okay? So there are many types of exercises they can do, but actually swimming is a really, really good exercise if you can motivate your patients to take it up. If you use assistive devices, if you use taping, that may help your joint. Ideally, you need a really posh brace which unloads most components of your overloaded joint. And I don't know if the chat is coming up or the PPTX is showing. You can use a crutch to offload the very bad joint. So what works? Some things work, but some things don't, and a lot of things that we thought worked don't seem to work. We are going towards holistic feet footwear, like not bits and pieces which are stuck to the foot, but like where the whole sole is modified with one material, not insole stuck here and there. So non-steroidal anti-inflammatory drugs work, but they are toxic and they have a lot of side effects in these patients. Paracetamol works somewhat, not very good. Topical anti-inflammatory drugs and capsaicin works very, very well, right? A lot of patients have chronic pain issues, and for those people, duloxetine works, right? But anyway, what I want to show you here is that topical drugs are very effective. You need to combine this with lifestyle modification. There is a place for intra-articular steroids. Paracetamol may not be as good as it was shown earlier, right? So these are the kind of things. So what should we not use? Right, bisphosphonates don't work. Hydroxychloroquine, methotrexate, anti-TNF, interleukin does not work. Glucosamines don't work. Chondroitin may be, but not glucosamines, though we all give it and patients love it. The trial evidence is not there. Platelet-rich plasma, which everybody is trying to sell nowadays, does not work in osteoarthritis according to the current research evidence. Stem cells also don't work. So there is a lot of things which people are advocating, which people are promoting, which do not work in osteoarthritis, right? So these are the things which really don't work. There are new treatments, but they are not yet available. And I wanted to just again show you what does not work, because people kind of use lots of things. I personally do give glucosamines because patients, it's a supplement and it has very little harm, but I object to injecting hyaluronic acid and platelet rich plasma. Fish oil, again, I see no harm. Right. So we've come to the end of my lecture. Before I end it, can someone please tell me, ask me any questions you want to ask about osteoarthritis? Oh, there are some questions. Cool. So, the question is, I'm hoping the chat will come up. Okay. The question is, it's a question. Okay. Can hand osteoarthritis patients do exercises? Yes, they can. Their exercises are mainly range of movement exercises. The main problem is with OA of the thumb. So you should not do swiveling movements like the ones where you open a doorknob. Right? Can you see like that? You open a doorknob, or this kind of movement, right? So those ones you should avoid, but there are no specific exercises targeted. They are mainly range of movement. If patients with rheumatoid arthritis end up with osteoarthritis, those patients are managed as osteoarthritis. You need to also control the disease activity of rheumatoid arthritis so that the osteoarthritis is not progressive. Oh, Siddhalepa. Now that Siddhalepa, I think they are topical ointments. Nice question. They are topical agents like the anti-inflammatory drugs and the capsaicin. And those ones work by altering the nociceptor input of the joint, right? So depending on how you massage in your Siddha Lepa, or what is their other oil which I have forgotten, Baraka oil, or how you massage in the joint, there may be some pain relief. But there are some trials of Ayurvedic treatment. I don't think Siddha Lepa per se has been tried, but because of the way the thing is massaged, there is a effect. Whether the agent, the drug agent works, I am not really sure. Okay, so what is the place for surgery? Surgery is reserved for people who have refractory pain, who cannot do what they want to do, and their life is significantly affected by the osteoarthritis. For those patients, surgery is recommended. If you have a malaligned joint, for those people also, you can use surgery. Cycling and swimming. Oh, no. So the next question is from Duvindu. Right. Is there any advice for the amount of exercise that should be done? Yeah, 10,000 steps was the limit if you're really starting anew. But if you're a regular, if you're an athlete who does regular exercise, there is no limit. Repetitive motion does not cause damage if your joint is well aligned and your muscles are strong. So that is the real answer to your question, that if your muscles are strong and your joints are not malaligned, there is no limit to the amount of exercise. But if your disease is complicated by malalignment, then, and your joint muscle strength is very poor, then there is a limitation. Walking should not be discouraged, provided they walk with soft surfaces, not on a treadmill, but on a soft surface. If they can walk, that would be fine. So I think I answered Muhundan's question, because joint replacement is not is not the end. end stage treatment of osteoarthritis, if you actually do correct behavioral management, 50% of patients on joint replacement lists can be not cannot undergo surgery. Okay, so the surgery is not the final common pathway of osteoarthritis. If you affect correct treatment ventures, you can avoid it. Okay, I hope I answered that question. It's a very good question. And orthosis and prosthetic cost dependence. I don't think it's a dependence. So say I start off with osteoarthritis. I am 90 kilos and I am very flabby and I have spent all my time in front of the TV. And somehow my therapist get me moving and make me lose weight. And now I am 60 kilos or 50 kilos, and in those people you might be able to reduce the prosthetic use because the joint load is less. But if you have a joint malalignment, you will have to use the prosthetic. Orthoses are helpful things, no? So I think you can continue to use. There is no dependence as such. It's just let me put it like this: internet is useful for your learning. So but internet use can become an addiction, but that is not the case with osteoarthritis devices. I hope that is clear. Okay, answer that. Tai Chi and yoga, are they useful in preventing? All exercise which strengthens your body is useful in preventing osteoarthritis. Acute flare-ups with a joint effusion, drain and inject. That is the treatment of knee joint effusions. Is the management of osteoarthritis secondary to rheumatoid arthritis different from pure and simple osteoarthritis? Only in that you have to manage rheumatoid arthritis in addition to osteoarthritis. Also, the pattern of joint involvement is different in rheumatoid arthritis. Secondary OA, for example, normal osteoarthritis causes a varus deformity. In rheumatoid arthritis, there's a valgus deformity. So those patients may find surgery more helpful. I don't think alternate medicine should be discouraged if it is not harmful. But if alternate medicine is invasive or expensive, I discourage them. Okay, I don't want people to spend 30,000-60,000 on platelet-rich plasma, which is injected to their knee if it doesn't work. But I don't mind them using a krill oil sent by their daughter in Australia if it's not going to cause harm. Okay. Have I answered your questions? I think I have. Any other questions? Okay. Any patient, there's a really nice question, right? Any patient who develops anemia needs to be investigated for anemia. Never attribute it to a side effect of the drug. You have to investigate for anemia. Any patient who is on multiple drugs is prone to gastric ulceration. Any patient who is older, particularly female, is prone to have menorrhagia, right? So you need to always check that the patient is not iron deficient, B12 or folate deficient. You need to check that the patient has no source of blood loss, okay, before attributing it to the side effect of the drug. Are there any other questions? Anyone has any more questions? You can verbally ask them. I don't mind. I'm sick of listening to me. Any more questions? Okay. So if there are no questions, I can conclude the lecture. We will upload this to your LMS. You can also email to my faculty address if you have any other questions. I apologize for the slow connection. This is a brand new connection, but it's still not working. This particular time is bad. So perhaps next time we can schedule at another hour. Okay? Right. If there are any questions, happy to answer, right? So, but the main principle I want you to tell and focus on when managing the patient is the diagnosis correct? Have I assessed how bad their disease is? Okay, right? And then only you treat the patient. When you treat the patient, you must see if you have treated and achieved your treatment target, right? And then if the treatment target is met by disease modifying drugs, you must think when you can reduce them. If the treatment target is not met, you have to change the drug. Osteoarthritis is different, but similar principles apply. Okay, so thank you and good luck. I look forward to seeing you soon. Okay.